Good day, esteemed colleagues and dedicated healthcare professionals. Today, we will delve into the comprehensive approach to pharyngitis, a common yet multifaceted condition encountered frequently in clinical practice. This lecture aims to provide an in-depth understanding of the pathophysiology, clinical presentation, diagnostic workup, and management strategies for pharyngitis, emphasizing evidence-based practices to optimize patient outcomes. Pharyngitis, or sore throat, is an inflammation of the pharyngeal tissues and can be caused by a wide array of infectious and non-infectious agents. While most cases are viral in origin, the primary clinical concern often revolves around group A beta hemolytic Streptococcus, GBHS, due to its potential complications, including acute rheumatic fever, a preventable condition with timely intervention. Etiology: infectious causes, bacterial agents, Group A beta hemolytic Streptococcus, Streptococcus pyogenes, Group C and G Streptococci, Neisseria gonorrhoeae, Archaeobacterium hemolyticum, Corynebacterium diphtheriae, Haemophilus influenza, Chlamydophila pneumoniae, Mycoplasma pneumoniae, Fusobacterium necrophorum. Viral agents: respiratory viruses, rhinovirus, adenovirus, parainfluenza virus, influenza virus, coronavirus, Epstein-Barr virus, EBV, herpes simplex virus, Coxsackie virus, human immunodeficiency virus, HIV, fungal agents, Candida albicans, non-infectious causes, allergies, irritant exposure, inhalation of irritant gases, gastroesophageal reflux disease, GERD, sleep apnea. Pathophysiology and clinical presentation: Group A beta hemolytic Streptococcus, GBHS, pharyngitis. Epidemiology accounts for 5 to 25% of sore throats in adults presenting for throat culture, more prevalent in children than adults. Clinical features: acute onset, sudden sore throat with difficulty swallowing. Pharyngeal findings: erythema, tonsillar enlargement. Exudates, more common in children. Systemic symptoms: fever greater than 38.3 degrees Celsius, 101 degrees Fahrenheit, cervical lymphadenopathy, tender anterior nodes. Absence of cough and rhinorrhea, suggestive but not definitive. Complications: suppurative, peritonsillar cellulitis and abscess, edematous, inflamed tonsils, grayish-white exudate, high fever. Rigors: requires drainage and antibiotics. Retropharyngeal and parapharyngeal abscesses, otitis media and sinusitis, non-suppurative, acute rheumatic fever, preventable with timely antibiotic therapy, occurs typically in ages 5 to 15 but can affect adults. Acute glomerulonephritis, not preventable by antibiotics. Viral pharyngitis. Clinical features: respiratory symptoms: cough, rhinorrhea, conjunctivitis, hoarseness. Pharyngeal findings: erythema, possible exudates, less frequent than in GBHS. Epstein-Barr virus, infectious mononucleosis. Clinical features: prodrome, malaise, headache, fatigue. Acute symptoms: sore throat, most common, fever. Pharyngeal findings: enlarged tonsils. Erythema, exudates, in 50%, palatal petechiae, lymphadenopathy, anterior and posterior cervical nodes, generalized lymphadenopathy, splenomegaly, in 50% of cases, hepatomegaly and hepatitis, in 10%, rash, especially after amoxicillin administration. Other notable pathogens: Neisseria gonorrhoeae, may cause pharyngitis in sexually active individuals. Corynebacterium diphtheriae, causes a pseudomembranous pharyngitis, rare in immunized populations. Fusobacterium necrophorum, can lead to Lemierre's syndrome, consider in severe pharyngitis in adolescents and young adults. Candida albicans, associated with immunosuppression or antibiotic use. Diagnostic workup, clinical assessment, history, symptoms, onset and severity of sore throat, presence of cough, rhinorrhea, or conjunctivitis, difficulty swallowing or breathing, previous exposure to strep infection, risk factors, Age, higher risk in children and adolescents. Sexual history, 4N. Gonorrhea, immunosuppression, HIV risk factors, recent antibiotic use, risk for candida. Physical examination, pharyngeal inspection, erythema, exudates, tonsillar swelling, palatal. Petechiae, lymph node examination, anterior and posterior cervical nodes. Additional findings, rash, e.g., scarlet fever rash, hepatosplenomegaly, signs of dehydration or respiratory distress. Centor Criteria, modified. Assign 1 point for each: fever greater than 38.0 degrees Celsius, 100.4 degrees Fahrenheit, absence of cough, tender anterior cervical lymphadenopathy, tonsillar exudate or swelling, age modification, at 1 point if age 44 years, laboratory testing, rapid antigen detection test, RADT, advantages, quick results, minutes, high specificity, 95-99%, limitations, variable sensitivity, 70 to 90%, negative results in high-risk patients should be confirmed with throat culture, especially in children and adolescents, throat culture. Gold standard, results available in 24 to 48 hours, recommended when RADT is negative in high-risk patients, monospot test, heterophile antibody test, use, suspected infectious mononucleosis. May be negative early in the illness, consider repeat testing, complete blood count, CBC, findings in EBV, lymphocytosis with atypical lymphocytes, possible thrombocytopenia, specific serologies, EBV serology, IgM and IgG to viral capsid antigen, HIV testing, consider an acute retroviral syndrome, use HIV RNA PCR, other tests. Throat swab for gonorrhea, use Thayer-Martin media, KOH prep for candida, demonstrates yeast forms. Management strategies, goals of therapy, alleviates symptoms, prevent complications, rheumatic fever, suppurative complications, e.g., abscess formation, reduce transmission, treatment of GBHS pharyngitis, antibiotic therapy, first-line treatment, penicillin V adults, 500 mg orally twice daily for 10 days, children, 250 mg orally 2 to 3 times daily for 10 days, benzathine penicillin G, adults, 1.2 million units IM single dose. Advantages: ensures compliance. Disadvantages: painful injection, higher risk of allergic reaction. Penicillin allergy alternatives: azithromycin dose 500 mg on day 1, then 250 mg daily on days 2 to 5. Note: monitor local resistance patterns. Cephalexin dose 500 mg orally twice daily for 10 days. Use in non-anaphylactic penicillin allergies. Symptomatic treatment: analgesics/antipyretics, acetaminophen or ibuprofen, throat lozenges and warm saline gargles. Treatment of other bacterial pharyngitis: Archinobacterium hemolyticum. Treatment: penicillin or erythromycin, Neisseria gonorrhoeae, ceftriaxone. 250 mg IM single dose, plus treatment for chlamydia trachomatis if not excluded, Corynebacterium diphtheriae, antitoxin administration. Antibiotics: erythromycin 500 mg orally 4 times daily for 14 days. Penicillin G may also be used. Fusobacterium necrophorum. Consider empiric coverage with penicillin VK or clindamycin. Monitor for signs of Lemierre's syndrome. Treatment of viral pharyngitis. Symptomatic management: analgesics, hydration, rest, lozenges, influenza-related pharyngitis, antiviral agents if within 48 hours of symptom onset. Management of infectious mononucleosis, supportive care, rest, hydration, analgesics, avoid ampicillin/amoxicillin, due to high risk of rash, steroids. Reserved for significant tonsillar hypertrophy causing airway obstruction. Treatment of pharyngeal candidiasis. Nystatin suspension, 5 ml swish and swallow 4 times daily. Clotrimazole troches, 10 mg dissolved orally 5 times daily. Patient education. Importance of completing antibiotic course to prevent rheumatic fever and complications. Symptom management strategies. Avoidance of antibiotic overuse. Explain viral versus bacterial infections. Discuss risks of unnecessary antibiotics, resistance, side effects, when to seek further medical attention, worsening symptoms, difficulty breathing or swallowing. Signs of complications, e.g., neck swelling, drooling, follow-up and referral. Routine follow-up not necessary for uncomplicated cases. Indications for referral to ENT specialist: recurrent streptococcal pharyngitis, peritonsillar abscess, suspicion of diphtheria or other serious infections, consider tonsillectomy. In cases of recurrent streptococcal infections unresponsive to medical therapy. Key takeaways: diagnose judiciously, use clinical scoring and targeted testing to avoid overuse of antibiotics. Treat appropriately, tailor therapy to the etiology, prioritizing antibiotics for GBHS to prevent complications. Educate patients. Clear communication about the natural course of pharyngitis and proper use of medications ensures better outcomes and satisfaction. By combining clinical acumen with evidence-based management, we can navigate the complexities of pharyngitis and provide effective, patient-centered care. Dear colleagues and esteemed learners, as we conclude this comprehensive exploration of pharyngitis, I want to extend my heartfelt gratitude for your attentive participation. Your dedication to enhancing patient care and expanding your medical knowledge is truly inspiring. If you found this lecture insightful and enriching, I warmly invite you to like this video and subscribe to our channel. By doing so, you'll stay connected with our community and gain access to more in-depth lectures, case studies, and valuable resources tailored for healthcare professionals like you. Together, let's continue to learn, grow, and make a positive impact on the health and well-being of our patients.